Good afternoon, everyone. I'm Huiling, your host. Thank you for joining our webinar today on Value of Cochrane Reviews and Strength of Methodology, presented by Sumitra Delta. Before we get started, I would like to go over a few items so you know how to participate in today's event. The webinar is recorded and you can watch again after the session. You can submit your questions by typing them in the questions pane of the control panel. You may also send in your questions at any time during the presentation. We will collect these and address them during the Q&A. There will be a certificate that will be issued to all participants after the webinar. Please keep a lookout for the post-webinar email, which will be sent out in the next few days. Today, we have the pleasure of having Sumitra with us, and I would like to give a quick introduction. Sumitra is a consultant psychiatrist working in Tata Medical Center, Kolkata, India, and holds an honorary dual affiliation with the UCL Institute of Clinical Trials and Methodology, University College London. He has been a Cochrane reviewer for more than 15 years. His current research includes systematic reviews, psychological and social aspects of health, decision-making, and health communications. Without further ado, I'll hand it over to Sumitra for your presentation.
Thank you, Huiling, for your kind and generous introduction. Welcome to the Cochrane webinar today. And I would wish you good morning, good afternoon, good evening, depending on where you are. We have participants registered with us from Brazil to Australia and China and lots of countries in Southeast Asia. So, before we start, I think we need to understand what is Cochrane emphasizing to doing. Now, this is the exam scenario situation, and lots of our people whom we know may have gone through exams, and they give that I have got 5 straight A's, or Daddy, I have got 90%, and often that means that people only look at the top 5 subjects and discount the 2. Now that's what often even done by adults when people talk about evidence, and Cochrane looks at the good and the bad and then gets a balanced view of it, and that's where the value of Cochrane reviews are. Before I start, I would like to say that my conflict of interest is that I'm a lead reviewer for Cochrane Schizophrenia Group for the past several years. And I have also corresponded with Carla, who is the editor-in-chief of the Cochrane Library. And she was kind enough to sort of collaborate and give some of the 4 or 5 slides which I'll be using. And I would like to acknowledge Murai Umakwit, who heads the knowledge translation team, from whom I have learned a lot about Cochrane collaboration in the last 1 year, and all my colleagues in Cochrane Schizophrenia Group. So these are the people I would not have been here without their inputs for me we have learned together. Now, what would we talk about in today's talk? It's about what is the necessity of having systematic reviews. How is Cochrane systematic review special, and is there anything rigorous about it, and does it actually matter? Does it matter that good quality Cochrane reviews actually influence policies? And Cochrane collaboration is also doing a lot on engaging the larger community of people, the service users and everybody else. So we would talk about that as well. Now, what is the relevance of systematic reviews in clinical medicine? And what do, as doctors, jobbing clinicians like us, what do we want? We want evidence that is internally valid. So we need something which we would consider the truth. However, at the same time, you do need evidence which is applicable to your setting. We are going through COVID-19 pandemic, and there were lots of interventions which people with all good intentions had talked about in the beginning, and later on we found that maybe it's not that useful for everybody. And Cochrane reviews actually are extremely important when you actually have to get a review which is applicable to your setting, but at the same time, your local area has to look at the reviews and see the costs, the benefits, and all those factors which you are sort of doing. Now, the evidence also needs to be comprehensive. So it needs to take into all studies, not just those which are easily available. And I'll talk about that a little bit later on. And it needs to be up to date. So Cochrane reviews are updated. And it should only not talk about the usefulness of an intervention. It also should talk about the harms associated with the intervention. So I think that those are things which we need as doctors, as clinicians, psychologists, or anybody, a health professional. Now let's talk about a sort of an example situation. Mr. Jones is a 72-year-old man with advanced prostate cancer with bone mets. And people with prostate cancer may have an advanced disease, but they may not die of that cancer. They may have a long life. So he visits your clinic and is in pain in his bones. And sometimes he says that I'm forgetful to take medicines. And as Steve Jobs often said, and one last thing, when I do consultation, sometimes a very crucial part of the consultation comes at the very end, where the patient says, "Doctor, also." So this patient had told us that I also have constipation at the time when he was leaving. So then you had already made up your mind to prescribe an opiate, because other medications have been tried and had not worked. And now you're thinking that if you prescribe morphine versus a fentanyl patch, which is a sustained release preparation, and the person doesn't have to remember, and he can change every 3 days from his skin. So which one would give better pain relief and which one would cause less constipation? Because that's the goal. Now you could, how would you answer this question? You could, conduct a trial. Is it possible? Is it realistic? No, because by the time the trial is completed, this patient may not be there and may be in significant degree of pain. So that's not realistic. Such an appraise the relevant RCT. That's also takes time. We will see it takes time. You can, people might actually think about doing a systematic review and phone a friend. I think most doctors would phone a friend if they don't know, but the friend might actually know the evidence based on what they have read in the evidence-based, sort of journey which they have had. Now, Cochrane collaboration could answer these questions appropriately, and the importance of the systematic reviews are because they take into account all the factors which I had told. And the what is a systematic review? Systematic reviews are a process through which evidence is collected on a particular research questions in a systematic, methodical way. Now, there is also a critical appraisal of whatever you get from your search and the evidence base, and then there is a statistical analysis of that. And only the statistical analysis part is called a meta-analysis. So sometimes people ask what is the difference between systematic review and meta-analysis. Systematic review is the entire process, whereas the analysis is the meta-analysis. And you could, be in a situation where you don't have enough number of studies, or the studies are so different from one another that you can't do a meta-analysis in a particular systematic review, but it's still important to do a systematic review. And it also identifies uncertainties, unanswered questions in a particular area so that future researchers could look at them. Let's interact. Hui-Ling, if you could give the audience the first two questions, please.
Yeah, so I have actually launched the first question right now. If the audience, you are looking at your screen, the first question is, which type of review rigorously look at the methodological quality of studies? We have 4 different options. So the first one is systematic review, narrative review, historical review, and scoping review. I will give some time for the audience to vote. Then afterwards, I will read out the results to our speaker. So a few more seconds. Okay, let me just close the poll and share the results. So a majority of you voted that systematic review is the type of review that rigorously look at the methodological quality of studies. 31% of you voted on that, followed by narrative review, And at 3%, we have historical review and scoping review.
Fantastic.
So
I can see
yeah,
the results of the poll as well.
that's good. Should I move on to the second question?
Second question, please.
Okay. Okay. Let me show the second question. So I'm now launching the second question. Which of the following is not needed for a systematic review? Please choose one of the options that you are looking at on the screen. Specific research question, agreed protocol, defined search strategy, or meta-analysis. A couple of seconds more before I will close the poll and share the results. Okay, let me stop and share the results for this question. So most of you selected meta-analysis, then agreed protocol, then specific research question, and define search strategy.
Yes. Yeah, thank you, Huiling. That was wonderful. And how many people have actually participated in the polls roughly?
Around 66% of the people over here voted.
Oh, that's
Yeah.
impressive. So all of you are active learners. So that's very, very gratifying for people to know. So I think, it's very important that we understand that, yes, the first one you got it, that it's how it should be. And in second, you don't need to have meta-analysis, but you do need all the other things which we talked about, that you need a protocol to be and in Cochrane Reviews it publishes the protocol, but I think it's important that you have a protocol even if you're doing a systematic review outside Cochrane. Now, what is the process of preparing systematic reviews? So the Cochrane collaboration, if you go to the website, you'll be able to see that there are lots of groups, so there could be a child health group and respiratory medicine. There are several groups related to cancer, so there could be one group on urological cancer, on one group on breast cancer. So in psychosis and schizophrenia, there is a Cochrane schizophrenia group. So you actually express your interest to do a systematic review to the particular group under which the topic is sort of relevant to. And then there is a process of registering the title in which you actually define the specific question. And I'll come to that in a bit because it has to be very specific. Sometimes, authors might be very broad in their questions and the reviewers might get back to you saying that be more specific. And at that stage, you would also want to have a competent author team. And the group I belong to often prefers that you have authors from more than one country, or at least definitely not all based in one institution. So we have authors. Last year we had a systematic review published. So we had two reviewers from India, one from UK, and Australia. So I think that actually makes it quite balanced. The next stage, once the title is registered and the group says it's okay, we can proceed to the next stage. So then you write the protocol. The protocol has PICO, which many of you might be familiar with. So for our patient with prostate cancer, so ideally a systematic review should be on advanced prostate cancer or metastatic prostate cancer. That's the patient group. And the intervention could be fentanyl, which is one medicine. And the comparator, C is for comparator, so that could be sustained release morphine. And the outcome assessment, in this case, there should be a standardized outcome assessment of pain by a visual analog scale, or all the kinds of pain questionnaires that people use, and you describe that methods in details. Now, when you do this review, it might take you, I will go through the steps of this. Then you submit the review. The protocol is peer reviewed and published. So Cochrane Reviews, one of the advantages is that you can actually read the protocol of any ongoing review. It's actually published, and on submitting it, it may be peer reviewed more than once. It's quite rigorous, and then once you submit it, you identify, appraise, synthesize all the evidence, and you publish this thing. And after a few years, there might be new randomized control trials coming out. So you update the review. The same author groups usually update the review. So this is the linear process which goes on. I will also, get a little bit about what we were talking about, that formulation of the question for you. So as I had mentioned, so advanced metastatic prostate cancer is a patient group, fentanyl is the intervention, morphine could be the control, and the outcome is a standard measure of pain. Now, this gentleman also talked about having constipation, like many elderly men do. So you should have a secondary outcome in the review that among the patients with metastatic cancer who are prescribed any of these medications, what is the incidence of constipation? So is it common or not? Now, you may think that is there, what is the justification in being so specific? Because, as young authors, when you start off, you might want to do a systematic review in the topic or the field which you are working in. And that's too broad, like you can't do say, I work with lots of patients with cancer, so you can't do a systematic review on patients with cancer having depression. So because it could be early cancer, it could be metastatic cancer, it could be breast cancer, it could be other kinds of cancer. So I think it's important that you have a specific patient group in mind rather than being it very broad. Now, so I think you do need to look at a PICO question also, which is relevant to what you are doing. So this is a disease which you think that people would be interested in finding the answer about. So, and there are lots of topics which could be looked into if you work in that area clinically. The next stage of the systematic review, say you have done the protocols and protocols been accepted by the review group, is how do you do the search? Now, the search, the review groups would often have people who are specialized in doing searches in the topic that they review. So in Cochrane Schizophrenia group, there is trial search coordinators. So they would actually help you to get the database. They already do updated searches on all topics related to their area. So there are specialized people who would be able to give you a search done with a date and a published methodology in which the search has been taken out. Now, I think it's also important that you don't do a search which is just convenient. So in many of our reviews, we have included Chinese trials, and that too, our first review published in 2006 had 2 Chinese trials. Now, Chinese trials are often published in those days, particularly, used to be published in journals in China. So there has to be an abstract, you have to have access to those abstracts and be able to, we had a collaborator who knew Chinese. We were in Leeds at that time in United Kingdom, and she helped us with that part of this review. So helping us to come out with 2 or 3 trials which we felt was relevant, and then we went into the details of those studies. So I think it's Ukrainian and Spanish, and so some languages have a lot of publications which are not in English. So if you could actually be comprehensive, that would make your evidence, as I was saying, more valid. The screening of bibliographies of included studies, that's another trick which I would always recommend, that for those authors who have published a good quality randomized control trials, they might actually have gone through the literature which is relevant to the area they are talking about. And so you going through the bibliographies of the included studies is important. Hand searching is becoming less and less relevant today, but I think it still has some value if you're doing a review on a topic which has some evidence which is quite old, and in journals which do not have online presence till date. It's rare, but we did a review on childhood onset schizophrenia, which is very rare disease, happens in 1 in 10,000. So we had 2 studies which were published in 1977. So I think it's important that you take that into consideration, and hand searching do help in those sort of situations. Sometimes you have to contact the authors, particularly experts who are working in that field. And if you say that you are doing a systematic review, even if they don't share the data, but you could actually put it down as an ongoing study rather than an included or excluded study, then your authors, your readers would know that these are the 4 studies which are ongoing and would have the results soon. At times, you might even need to contact pharmaceutical companies if you're doing studies on medications. They may be able to identify studies which you don't have. Now, this is um, about something called a funnel plot. Now, I will tell you a little bit about this. So, in this plot, on the x-axis is the effect size. So, if you go to the top, the effect sizes become smaller, but the sample size, so the number of people included in a particular trial, becomes bigger. So, as you get larger and larger studies, you actually end up having sort of more precise estimates, but less bigger studies, less robust findings, sometimes less robust effect, because they are much more precise than earlier studies which may have not followed all the sort of this method. Now, if you see the graph on the right hand side, you will see that there are more studies on the right than on the left, which has a positive effect of the intervention. And this means that your search has missed some of the studies which may have not been published, because this is not a inverted funnel shaped. And this is something which is often published in Cochrane Reviews to show that what are the kinds of studies which have been included in the review. Now, the next process of looking at a review is performing an assessment of the quality. So this is done independently, often by 2 different reviewers, and the quality is, you need to look at, you could look at the randomization, the concealment of allocation. People do all sorts of things, like they don't really mention clearly how the randomization was done, particularly in the days when consort guidelines was not mandatory for many of the journals. So that's important, that the exact way the randomization was done is mentioned. There have been instances in the world that people used envelopes, and you could actually look at the group where the patient is allocated to, and there is a lot of bias, people who are conducting the studies. So in today's world, usually randomization is done with the help of a computer, and it's done such that it adheres to the consort guidelines for randomized controlled trials. Following the quality assessment, you do need to see, if it's adequately blinded. So blinding of the not only the outcome assessors, but we did a review on psychological interventions for adolescents with psychosis, which was published last year, and the people who were delivering the intervention in some studies were the same psychologists who had delivered it for the sham psychological treatment in the control group, and the same psychologist may have delivered the treatment in the treatment arm. So there, the person who is delivering the treatment is not blinded. So you have to go into the details. Of course, the allocation, the outcome assessment was done by most studies by a blinded assessor, but this could be a potential source of bias. Now, after you have gone through all this, the quality assessment, there is, I would also talk about grade approach in quality. So Cochrane Reviews, the way grade works is it's a separate software. So you increase the quality level or decrease the quality level depending on, if there is unexplained heterogeneity, it becomes 1 notch down. So you may have seen in Cochrane Reviews high quality evidence, moderate quality evidence, poor quality evidence, low quality evidence. So that is answered by following this grade approach. You don't sort of downgrade evidence more than 3. After it's very poor, there is no point. So it usually roams around on this high, moderate, poor, and very poor. So those 4 grades are applied for each outcome that you report. And if there is imprecision of results, so like 2 and with a confidence interval of 1 to 64 depending on what you are studying, so that's a very wide confidence interval. So then we would say that the results are imprecise, or if there is a high probability of publication bias. So these are things which you would look at. This is the risk of bias table from the review we published last year. So if you see, we had around 8 studies. So almost everybody had talked about how they had generated the random sequence. In today's world, you can't publish a randomized control trial without mentioning that. So 75%, if you see the graph on the right hand side, is green. So 75% of the studies had actually talked about how they had come out with a randomized control trial, a randomization, but 25% did not mention in their published report. On the other hand, when it went to blinding of participants and personnel, this was not true. So you can imagine the psychological interventions. If somebody is getting versus not getting, it's difficult to blind in that way. And people might actually, one patient might talk to the other patient as well, who is being treated in the same center. So there are problems. So we felt that many of the studies had high risk of bias in terms of blinding of participants and personnel. But for outcome assessment, I think most of the outcome assessors, again 75%, had actually used a blind outcome assessor. So you report all the trials in this grid, which is called a risk of bias table. Now, by this time, you have actually got this is a Prisma flow diagram. So when you read a systematic review, if you want to know if it is good or bad, so Prisma statement is the statement which you need to look at. Now, in a Prisma flow diagram, you have sort of recorded some of the studies. So after the search at the top box, you have searched so many databases, maybe PubMed, various other databases, cancer literature, Embase, EpiInfo, hand search. So all this has given rise to maybe 2,000 abstracts. Now, when you get those abstracts, some of them, when you sort of read them, you would be able to exclude them based on that they were not on the topic directly which we're trying to read. So I give an example. So if I am doing a study on atypical antipsychotics for psychosis, which we published a few years ago, so we saw that maybe there was a study on pharmacokinetics of the medication. So that's not a randomized control trial on antipsychotics in adolescents, but it's a good study, but it's not something relevant to the review which we are doing. So you exclude from the abstract itself. So that's at the top box. Now then, the rest of the studies, you actually read them. You have got, say, maybe after you have excluded from abstract, you might have, like 200 out of 2,000 left, which you have to read in details. So you get those studies, get the full text articles of those, and assess them for eligibility. Now, when you assess them for eligibility, you might have a situation where you exclude them. So if I am doing a review on adolescents, there are studies who looked at this group from say 16 to 25, whereas our predefined inclusion criteria was a study done on adolescents, which we defined as somebody who is 13 to 18 years of age. And 75, if there is overlap with adults, we said that at least 75% of the population which is included in the trial should be between 13 and 18. Or if it's a very large study, there should be data available separately for this adolescent age group. Now, that excluded a lot of studies. From 16 to 25, if there is a study reported, published in a good journal, where the mean age is, say, 24 plus minus 5 years, that means it's clearly not in the age group that we are looking into. So that is excluded. But you have to maintain a database, maintain a record of the reason why you excluded each of those studies. And then you come to those studies which are included. Now, when you do data extraction is usually done from forms, and there are actually written forms which you do. So you in Cochrane reviews, you usually take only the post-intervention scores. It could be continuous outcome measures or categorical outcome measures. And depending on the measure, you use either a risk ratio or an odds ratio if it's a categorical measure, or you use a mean, standardized mean for a continuous measure. Now, when you do a data synthesis, most reviewers begin the analysis with a simple tabulation of the characteristics. You do have to describe your sample which you are giving the review. So we had 8 studies, and they were done mostly in high-income countries. However, there were 2 studies from low and middle-income countries, and this was the rough age group which they had studied, and so on and so forth. And then I'll take you through the forest plot a little bit, because that's again quite interesting, and you would all be wanting to know the result of each component of the study. And this is the graph which you often look at. Now the line of no effect is the line at which where it could be useful versus it could be harmful. Now each of these horizontal lines depict one trial. Now the trials, the whiskers of these boxes is the confidence interval of the outcome we are measuring, and the middle of the black box, which is the trial, is the mean of that outcome measured. So each outcome has a mean and a confidence interval, or an odds ratio and a confidence interval, and the overall effect is depicted at the bottom of the forest plots by a diamond, and the middle of the diamond is the mean effect or the average effect. And as you can see in this one, a large number of studies actually have crossed the line of no effect. However, the overall effect, it is showing that there is some effect. That is possible, that might happen in some situations. So I think you will have an idea about how forest plots are done. Now, coming to a gentleman with cancer, pain, and transdermal fentanyl, there is a Cochrane review on cancer, pain, and use of fentanyl, but it is not specific to prostate cancer. And if you see the results, just to give you an example, so they haven't done a meta-analysis for the studies that have been included in this review. So they have described, 8 studies, but they have just described the score and the outcome measures, and they couldn't do because there is a heterogeneity of methods and different types of cancers. But they did the measures were different for the pain assessment, but constipation present absent. So if you see that they did report with a meta-analysis and a forest plot. So if you see the events of 45 out of 165 in the transdermal fentanyl group, that means 45 out of 165 people had constipation, whereas in the morphine group, sustained release morphine, 69 versus 155 had constipation in the first study published in 1997 by Ahmed et al. And like that, they have actually an event. This is again a categorical outcome, and it did show that transdermal fentanyl is associated with less problems of constipation. So you may be actually thinking about this, that for that particular patient, transdermal fentanyl might work better than sustained release morphine. Now, what is heterogeneity? Heterogeneity is that when you say that a group of studies is homogeneous, you assume all of the studies have used identical methodology and are done on the same similar populations, and the only difference between them is because of the random difference in the mean score of the outcome. Whereas in real life, studies might be heterogeneous and they may not be following exactly the same population. Population somewhere in a country which has a higher survival might recruit patients with cancer who have a mean age higher, whereas it may not be so in many low and middle income countries. So there might be heterogeneous studies in your review, and it's okay to have heterogeneous studies included in the review as long as that is not an unexplained heterogeneity. So if you can explain the heterogeneity, I think it's okay. Now, after you do all that, the reviewers need to look at they need to interpret what does all this mean, interpret the results. You should look at all these things, publication bias, what are the limitations of the primary study, limitations of the review itself. And often it's good for, I would encourage all of you to read the Prisma guidelines checklist, which is only 2 pages. Just Google Prisma guidelines, you will be able to get it. So, Quilling, let's do the second quiz, 3 and 4.
Yeah, I have just launched the third question on the screen. Where can you register the protocol of a systematic review? So let's give the audience some time for them to vote, and I will share the results after again. Okay, I will close the poll now and share the results. So majority voted Prospero as the place where you can register the protocol of the systematic review, followed by PubMed and CTRI, then EM-based. So I'll move on to the last question.
Yeah.
Okay. So I've just launched the last question on the screen. During meta-analysis of a group of heterogeneous studies, the authors should use fixed effects model, random effects model, both or neither. So please put in your vote again, and I will share the results again after. Okay, let me close and share the results again. So it's a close fight between the random effects model and for both models, as you can see. Yeah.
Yeah. No, I'm very impressed, feeling, because of our audience and their, So I think, I didn't purposefully tell the answers to these questions. So the first answer would be yes, you could publish a review in a journal which is in a PubMed, but Prospero is a registered outside Cochrane, which actually registers the review, protocols. Cochrane individual groups, of course, is a platform where you could. I didn't give that option here. For heterogeneous studies, as I was discussing homogeneous and heterogeneous, for heterogeneous studies, you do use the random effects model, not the fixed effects model. It reduces the impact. You might not get as high effect as in a fixed effects model, but that's where the truth probably lies. So thank you, William. You can close the poll. Thank you. So moving on, where do you find good quality systematic reviews? This is a rhetorical question. Sorry. This is, of course, we are doing Cochrane Reviews. So Cochrane collaboration has a large number of volunteers, 22,000 when I had checked. I think it's more now. And its main output is the Cochrane Library, which has a lot of reviews. So it's the largest organization in the world devoted to producing, disseminating, and maintaining systematic reviews. And any guesses in the chat box what this review is? It's a recent review published this year. I've hidden the. Any answers in the chat box? Huling, can you read the chat box?
Okay, I don't see any coming in right now.
Okay.
Yeah.
So, this was a review on digital contact tracing technologies in epidemics. It was a rapid review. So these are certain things which Cochrane did during the thing, and you may have a systematic review which is of questionable quality. So I think it's important, as I mentioned earlier, to read the Prisma statement. Now, what was the response of the Cochrane collaboration during COVID-19? Now, one of the things which people talked a lot in the early part of the pandemic was hydroxychloroquine. And if you can see, this is the graph of the sales of hydroxychloroquine in US, and this was reported by BBC. And you can see there was a sharp rise in the number of prescriptions in around May, March, April in US, which reduced, and people were confused. They were sort of tweeting, and the questions at that time we did not know, or could not ask, was there any evidence of chloroquine reducing mortality in COVID? Does the use of chloroquine increase adverse events for patients with other diseases which use chloroquine? What is the impact of not having the treatment available? These are things which you could ask. And I'm pleased to say that there was actually a review published this year on hydroxychloroquine in February. And if you see that, it had actually looked at hydroxychloroquine versus either standard care or placebo. And it had all sorts of outcome: death due to any causes, negative PCR after 14 days for COVID-19 virus, progress to mechanical ventilation, time to clinical improvement, participants with any adverse events. So, and participants with serious adverse events, and participants with prolongation of QT interval, because cardiac toxicity was something which people talked about a lot. And if you see that, as regards preventing death, it's only 18 per 100 in the sort of non-treatment arm, comparator arm, and with chloroquine it was actually more, 19 per 100. So this was considered by the authors and the Cochrane team, very poor evidence to show that there was a difference between chloroquine and not having chloroquine, and uh, the quality of this outcome was reported to be high quality outcome. So if you see in the summary of findings table on the fourth column, certainty of evidence grade, so in the first row it says high. So whereas if you go to the QT interval, it says very low. So you may not have, you may have a difference, but the evidence and the comments mention that the evidence is very uncertain about the effects of HCQ on prolongation of QT interval on ECG. So they have commented on that as well. So I think, that's where you do understand the importance of systematic reviews. Now, looking ahead, we also had to have innovative ways to keep up with the evidence. So there is a concept called living systematic reviews. So because so many trials are happening, if you can see, hydroxychloroquine, convalescent plasma treatment, ivermectin, and there are other antiviral treatments. In fact, in the last 12 hours, there is a Cochrane review published on ivermectin. The review concludes that there is very positive of good quality evidence to show that ivermectin is working for this, but patients are encouraged to be part of randomized control trial if they are on it. So the review concludes that the Cochrane review. So that's the way how people could be sort of informed, and more studies maybe is needed. Now, the active monitoring of new evidence and incorporating timely the new evidences. If there is, say, a large, randomized control trial on ivermectin published a few days later, that needs to be included into their review, and that's where a living systematic review and ongoing thing helps. The Cochrane collaboration and the World Health Organization also had a partnership, and they are doing network meta-analysis. So this website, NMA, network meta-analysis of Cochrane collaboration, it talks about all the trials that are happening around the globe and what their specific phases, what are they looking. You could change the map, you can choose the country, and you could see what is the stage of each of these trials are, and they're updated on a regular basis. Now, coming to the last question, how do you actually get the larger community to participate in understanding the findings of your review? I'm pleased to say that last year when we published, we also did some work along with the knowledge translation team, and we published easy summaries which people could read, and knowledge translation teams and us, we published some videos on the findings of our reviews, and it went on to become the featured review of Cochrane collaboration in July 2020, the psychological interventions for psychosis in adolescents. And I'm a psychiatrist, and that's my area. So we realized that we also published in a blog about how to make your reviews more visible. And as you can see, we collaborate with medical students, illustrators, and psychologists. So this becomes owned by the community, and it helps. And I'm pleased to say that the review has been published in so many languages. The summary, so French, Spanish, Malay, Chinese, um, so quite a few languages. Portuguese, it has been published. So you have a more visible. The Wikipedia page of psychosis also has changed based on our review, and they have quoted the outcome which we have come out about psychological interventions, and this is reaching out to the general public. So Cochrane Library is ranked 10th out of 165 journals in medicine and internal medicine category, and it has quite a high impact now, 7.9, and it's one of the journals which is, I think, quoted every few second once. So in 2019 alone had 67,000 citations. So I would like to conclude that meta-analysis and systematic reviews are important, and a meta-analysis should be conducted only in the context of well-done systematic reviews. Larger, more well-designed studies may have lesser effect, so that's possible. And meta-analysis may help in determining the overall effect of a specific intervention by taking into consideration various studies in the method that we spoke about. Thank you. So over to you, Huling, for any questions which may have come.
Yeah, thank you, Sumitra, again for the presentation earlier. So we'll now open the floor to collect questions and to address them. So please enter your questions in the questions panel and we'll pick them up. So let me, before I start on the first question, sorry, my camera isn't on. I would like to inform everyone that I've actually uploaded the slides for today's webinar in the handout section. So if you could take a look on your control panel, there will be a handout section and you will be able to download the slides which Sumitra has shared earlier. So let me start with the first question. The first question that I see is, at least how many RCT are required to conduct meta-analysis?
Sometimes you might be able to do meta-analysis. It's a very good question. So in Cochrane Reviews, you might want to do a different analysis from that what has been already reported by the authors. I'll explain by an example. So in usual terms, way outcome is expressed is number of people who have improved with a certain predefined criteria versus those who have not improved in the intervention and the control arm. Cochrane often looks at it like those who have not improved. That's a more robust way of looking at it. So you might be willing to do a forest plot even with one outcome measure. That's done in the Cochrane methodology. Very commonly it is done even with two studies. The idea is that both of them has to have comparable outcomes. So in a systematic review, which might have 8 different studies or 10 or 15 studies, but not everybody would use the same sort of outcome measures. So in psychiatry, they might use different scales or different outcomes. So you might have a forest plot with only 4 of those studies or 6 of those studies of the 8, whereas the other 2 also are good quality studies, but they may not have reported the same outcome. So you could do with minimum numbers. So it's possible to do it with small numbers. Thank you.
Okay, thank you for that. The next question is, would covidence be a tool for quality of assessment of studies?
Yes, it is. Thank you.
Okay, the next question that I see here is, how can researchers select the most appropriate tool for quality assessment? This is the first part of the question. And the second part is, when would the Cochrane tool be more appropriate when compared with other tools such as GRADE?
Cochrane uses the GRADE approach. It slightly depends on each of the disease groups. So the group I represent, Cochrane Schizophrenia Group, uses the GRADE approach, there is a free web software which is available. You have to incorporate. Most of the Cochrane review is done through a software called RevMan. So you have to include, sort of put all the data into the RevMan and then download it and share it with grade, and that gives you the risk of bias table. So grade is something which is standardized and is often used, but there could be topics where you have to use other methods of quality assessment.
Thank you. The next question is which kind of studies are evaluated in a systematic review? Is it only RCTs? How about retrospective studies which do not have information on randomization, blinding, etc.?
Yeah, that's a good question. I think by and large, the Cochrane movement started with encouraging good quality randomized controlled trials, because that's what it was all about. In today's world, there are systematic reviews on, say, diagnostic accuracy testing. So is a particular test able to diagnose the disease well or not? It could be done in the paradigm of an RCT, but it may not be. Or even there is a group even looking at qualitative studies and doing systematic reviews on them. All of these have different methodologies, but by and large, a large proportion of Cochrane studies are about intervention trials which follow the model of a randomized controlled trial. All that I have talked today is more or less valid for intervention trials, for randomized controlled trials. Now, unblinded case series, case reports, yes, they could be good in the sense that, if you give examples, say, from HIV to Alzheimer's disease to Parkinson's disease, all of them had been identified as a series of cases by astute clinicians. However, for interventions, I think in today's world, the best available sort of evidence which people rely on is a randomized controlled trial. So we are talking mostly about randomized controlled trials.
Thank you. The next question is, how is an update to an existing systematic review done? Does it have to follow all the steps?
Yes. So you do have to follow all the steps, unfortunately. So updating, you may not need to write the protocol again, because it will be the same protocol, but you still need to cover the, usually, say, the Cochrane reviews have a date on which the search was done, and most reviews are published within 1 year of the search being done. So you don't, if you get take too long to do the review, the review group might tell you that you need an updated search. Now, if you have published the review, the update usually includes only from the date when the last search was done to the date when the next search is doing. So so the published, you may have a review published in 2015, and in 2021, if you're wanting to update, so you do the hard work for 2015 to 21, but you don't redo again whatever was done till 2015. However, you have to incorporate each of the outcomes in each of the each of the studies for each of the outcomes which you're talking about, and also the interpretation may change because new evidence is always coming out.
Thank you. Moving on to the next question. There are two parts to this. So the participant mentioned that is curious about the new version of Prisma. Would you please explain more what the difference between the first layer and the second layer exclusion process? That's the first part. For the second part, what else should we need to take into account while choosing the model of fixed or random effect except for heterogeneous?
Okay, the first part of the question. So Prisma is a long checklist. It's it's difficult to go through it. We have limited time, all of them, but it's quite self-explanatory. Now, the first level of exclusion is, which I talked about, is about you obviously know that this is not a randomized controlled trial, but it came out, the abstract came up in the search because we had given certain search terms, a mesh term. So in a systematic review, say on a medication, for a particular disease control condition, like, say if I'm looking at psychosis, suddenly if abstract comes on, say, which is about family support. Now, that is a very important part of the treatment, but your review is looking at only a particular group of medication. So that you exclude, you don't have to go into the details of the paper, because you can exclude it reading on the abstract. That's the first level of exclusion. Whereas once you have got a pool of studies which you think that you could consider them, there the second level of exclusion could be because of more specific reason, that when you read the actual full paper, then you see that they may not have included the age group, the example I gave, of the patients that your review comes, because you have to have a very clearly defined criteria for the studies that gets included. So that's the second level of exclusion. But from the first and the second, in the second, for every exclusion, you have to read, if you read Cochrane reviews, particularly for Cochrane schizophrenia group, the reason for exclusion is actually mentioned for each of those studies. So if 200 studies have been excluded, 200 studies, the reason for exclusion for each of them are individually mentioned.
Thank you. I'll pick up just two more questions due to the time we have. So the next question that I see is, how do we get involved in specific group of Cochrane as a new PI?
Okay. Yeah. So usually it depends on the group and the area which you're working in. So there are some groups who would give them, so all Cochrane groups usually have a website and a published editor or an associate editor whom you can, of that group, whom you can write to, expressing your interest that this is the topic that you would want to do a review on. And now all Cochrane work is, as far as I know, done by volunteers. So nobody gets paid to do a Cochrane review. And that's the principle of Cochrane collaboration. And these, once you write to them, then they might accept the title and engage into this thing. They might actually get back to you saying that there is already a review underway on the same topic. There are some groups which actually calls. So I know of a group who actually gave sort of survey about what are the common topics in that particular area of study which the public wanted a review on, or the users of Cochrane systematic reviews wanted a review on. So based on that, they chose 10 topics, and after that, these 10 topics were published in the website of that review group, and anybody could apply, and then they had probably a way to shortlist whom they would allocate the review to. You should not feel disheartened. I think, like everything in research, you get rejections. You have to be able to understand that that's part of the process in research. So try again. Try a topic which you feel enthusiastic about. Write to the group. I think that's how, and that's the best way to learn Cochrane systematic reviews, is by actually doing one.
Thank you. The last question for today would be, what should be the best basis for deciding between or among, fixed and random effects model? Could you elaborate on that?
Okay, so if you have understood heterogeneity, so it's the statistical method, and you don't have to do the method. So Redman already have it in it to do the random effects model or fixed effects model. You have to choose in the software. Redman is a software which Cochrane uses for a systematic review, and it's given free of cost to the reviewers. So you can download it. You could use Redman for non-Cochrane reviews as well, but you need to, I think, take permission about it. So you have to make a judgment that, is this group of studies, based on the outcome we are seeing, is this heterogeneous enough? I think in today's world, it's best to use a random effects model commonly than a fixed effects model, unless you are doing research on a very niche area where very specific things are being studied for a small subset of population. So I think usually random effects model would be preferred by most of the review groups. So primarily, it's the heterogeneity which would decide which model you would use. Thank you.
Thank you for that. So, do you have any more last words before we wrap up the session?
No, I mean, I should like to thank Wiley and Hewling for helping us with this webinar and the software platforms and everything. Thanks to you for conducting it so well. Thanks to the audience for being so engaging, participating from all quarters of the world, asking relevant questions. So happy learning, and off you go. In the next 2-3 years, we should be able to see lots of you writing systematic reviews.
All right. Once again, thank you, Sumitra, for taking time to share your experiences. A big thank you to the audience as well for joining us today. I hope you find this information useful. Keep a lookout for Wiley emails on more webinars like this. Have a good day ahead and see you at our next webinar. Goodbye.
Goodbye. Thank you.